This is a very difficult case that I had recently. It's a patient with a non-maturing fistula in the left upper extremity. As you can see, the arterial anastomosis was a surgical fistula, and the arterial anastomosis here is a radiocephalic fistula, but it's not maturing. And the reason it's not maturing is because this part of the vein is very atretic. What I usually do in this case is I use a 3 French catheter and I put in the brachial artery so I can do an arteriogram and I can have an idea of the arteries and take a look at the veins without getting any spasm. And that is what you're seeing here. We then get a second access in the cephalic vein towards, usually in the upper arm, I usually do to avoid spasm. And then we access towards the arterial anastomosis, which is again right here. And you can see this whole segment is pretty atretic, not developing. And then, as we normally do, we dilate this area with a balloon, having a hard time to dilate, very close to the anastomosis there. You can see an arrow in here, but we dilate. This is a 1/8 balloon that we're using. And then right after we do an angiogram, and what you can see is a perforation in this area, which is right next to the arterial anastomosis. So a tough situation. So how do we handle that? The other issue is I was able to get a wire here, but because the way that the arterial anastomosis was done was very hard to get a wire going proximally into the radial artery. I couldn't just put a stent across this area would occlude the inflow of the artery. So initially, I put a balloon here to obviously occlude the flow and prevent more bleeding. After ballooning, it was improved, but you can still see some bleeding here that didn't improve. What we did was to get a wire from the brachial artery going down, and we were able to get this wire across the arterial anastomosis into the cephalic vein, as you can see here. We were able to snare that wire from the cephalic vein and externalize it. So, and at this point, we had a wire going from the brachial artery down the radial artery through the arterial anastomosis and into the cephalic vein. This is just essentially spasm from the artery, so we're not worried about that. We then placed a via bond going from the radial artery through the anastomosis into the cephalic vein, going from here to here, and the stents were deployed. Now at this point, we could post-dilate vigorously the area of stenosis since we had a covered stent there. This is the final result. You can see that there's no more bleeding. The anastomosis looks good. There's some area here, but this was a spasm. We did post-dilate this area with a balloon and we got a better result. The patient started using 2 weeks from that and came back for the follow-up in a few weeks, and it looks great. The fistula is maturing. He's been using the fistula now for a few months. The cephalic vein looks nice and the central veins look nice. So nothing else needed to be done.